Dr. Caitlin Northcutt. I'm an assistant professor in the College of Public Health at the University of Kentucky. I'm in the Department of Health, Behavior, and Society, and I'm an affiliate faculty member at Kiprick. My training is in developmental psychology, so I look at driving behavior and driving risk and injury prevention from a lifespan approach. And so today I'll give a little bit of background about what I mean by driving mobility and what we and how we operationalize that. And then I will do a very quick overview, because I know I stand between you and going home, on an individual level study that we're doing, looking at driving behavior in older adults who have mild cognitive impairment or early Alzheimer's disease, to start addressing transportation needs that they may need as they progress through the disease, as well as a pilot study that I am involved with that's collaboration with the Kentucky Transportation Center that's funded through KYTC, looking at social determinants of health and how it relates to crashes here in Kentucky. All right, so as many of you in the room probably already know, in terms of crashes and injuries, crashes are preventable. We try to use that word instead of accidents. And over 100 people die from crashes every day here in the United States. So if we look at in 2020, which is some of the most recent data, although I think 2021 data is now out, crash-related injuries contributed to over 2.1 million ED visits in the United States, and crash-related fatalities result in over 430 billion in total costs. So it's not only is it a burden in terms of injury and loss of life, but it's also costly. So Kentucky is ranked 6th in the US for highest fatality rate per 100 million vehicle miles traveled, and this actually increased from 2019 to 2020. And so I think what's uniquely challenging for Kentucky is that over half of our driving occurs on in rural areas, on rural roads. And so 64% of our crash fatalities in Kentucky usually occur on rural roads. And the contributing factors include a multitude of things, such as low seatbelt usage, which Bill Bells mentioned earlier today, larger vehicle size, roadway environment, and from a healthcare access perspective, emergency response times and medical access. Is there a way to make this go away? It's kind of distracting. So in terms of driving as an everyday function, so driving is a primary method of transportation for most adults here in the United States. In other countries, it's not the preferred method to get around, but we are a very car-centric country. So for when you speak with people of all ages, but predominantly middle age and older age, their primary method of transportation is driving their own vehicle. And it's the second leading cause of unintentional injuries death for adults ages 65 and older. But some promising data shows that from 2021 to 1997, older adult involvement in fatal crashes did decrease by 11%. So it's not the case that we're necessarily seeing increases in the problem, although any death we want to try and prevent. So driving is one of those behaviors that's uniquely impacted by both age and disease, and we think that's because the foundational pillars of driving rely on motor, sensory, and cognitive functioning. But it is important from a public health perspective to not paint the narrative that older drivers are risky as a whole, and when in reality, when you compare them to their younger counterparts, such as young drivers or novice drivers, those are actually the riskiest drivers on the road when you control for the miles that they drive and the length of time that they're driving, so their driving exposure. So in my research, what I try to focus on in terms of getting the basic research and then working with clinicians and practitioners to translate that into practice is focusing on drivers with health and cognitive issues, as they are likely the most vulnerable. And because of their chronic health conditions, probably need to be at the doctor's office a lot, right? And so when we're talking about how to get them there and how to promote health, positive health outcomes, transportation barriers is a big issue in this arena. And as a psychologist who's trained in longitudinal design, one thing that I find really interesting about driving that others may not consider is that this is a common behavior that you see across many individuals, and it's repeated over time. So you can look at it from a within perspective as well as a between perspective. So a concept that I like to talk about with people who aren't familiar with mobility is this idea of life space mobility, and this is how much an individual can move around in their environment. So when we talk about driving mobility, we're putting that same lens through driving. So obviously you can see in this figure, which is adapted from Peel and colleagues in 2005, life space starts from an individual's bedroom and then expands out to their home, to their outside home, their neighborhood, town, and unlimited. So when we're talking about driving mobility, we're talking about from the home onward, and how that person moves around in their environment using a vehicle. Now, the reality is that people can move around in their environment by other means, but in my research, I primarily focus on driving. So what we see for older adults is that it's very common as someone ages, they may start to restrict their driving behaviors. And it usually starts with perceived driving difficulty. They may think that they're having issues in certain types of driving situations, high-risk situations like making a left-hand turn or cross traffic. Now, the person is judging their own ability. They may have, co-pilot information from someone who may be scared to death riding with them, but the reality is that this is their judgment on their ability. And from there, if they perceive that the danger is high enough, they can then restrict their driving. And that could be in a multitude of ways, including driving space. So how far they go out in this mobility perspective, maybe they're just going to stay around in their neighborhood or town and not venture out any further than that. And they can also go to driving exposure. They can start to actively avoid the high-risk situations that they perceive as difficult for themselves. And that can be consciously or subconsciously. And then ultimately, the most restrictive form of restriction is driving cessation. And this is where the adult driver permanently stops driving, whether it be through their own means or someone in their family taking the keys from them. And I think it's important as we have the conversation in terms of independence and functionality and how we balance that with safety, is that driving cessation or retirement is probably necessary for a certain proportion of older adults, right? There comes a point where the provider and the family have to work together to assess the safety risk. And so as a psychologist, and I know the importance of driving and being able to move around freely in your environment the way you want to, that can be associated with negative social and health consequences if it's done too early. Or if it's done without adequate resources. And that's, I think, a big push in the older driver sphere right now, is connecting families with resources earlier so that it's not this crisis situation when someone's grandma accidentally has a fender bender, right? And they need to determine whether or not she should keep her license or her keys. So putting resources in people's hands early enough so that that person can be an active agent in their planning for aging, I think is important. So there are different ways that we study driving. We can look at it through retrospective crash reports, which is something that I do with the Kentucky Transportation Center quite frequently. We have self-informant reports, naturalistic observation, OT driving assessments, and then driving simulation, which I'll touch on in a few minutes because that is one of the methods that we do at the University of Kentucky. So again, I'm going to briefly talk about an individual level study that we're conducting right now, and then the population level one. So the individual level one is looking at cognitive reserve and driving mobility in adults with cognitive impairment. So for anyone in the room who's not familiar with Alzheimer's disease, it is the most common form of dementia here in the United States, and approximately just over 5 million Americans have a diagnosis of AD. And by 2050, we expect this to increase anywhere from 12 to 16 million. So some of the research that I do looks at gender and sex differences. We do know that women make up about 2/3 of the cases of Alzheimer's disease. And this, to what we suspect, is potentially because women live longer. And so they're living longer with the disease. So therefore, they're making up a bulk of the diagnoses. But there is a lot of research to look at the biological differences as well. It's just that research is not as concrete. So in terms of impairments in everyday function, how the individual is functioning, and then any impairments you see is how clinicians will diagnose disease progression. And so they're looking at severity as well as any loss of independence and reduction in quality of life. And I think that's where driving really comes into play, because this is a key everyday function that most people are doing on a daily basis and can be one of the early areas that families start to notice that there's impairment. So what's interesting about Alzheimer's disease, and I won't get into like the biological components of it too much today, but the idea is that not every individual who has predisposition for Alzheimer's disease or even has mild cognitive impairment will further develop worse symptomology in terms of dementia or actually have a diagnosis of Alzheimer's disease. It is on a continuum, and we do see that people float around a little bit on it. And one of the proposed mechanisms for why an individual may progress into Alzheimer's disease or not is what we call cognitive reserve. And this allows for cognitive performance that's expected given the degree of life course brain change pathology a person may have in relation to their performance. So they may have a lot of Alzheimer's disease pathology in their brain, but when you look at their functioning, they're not showing impairment, right? And so this is alluding to scientists and to doctors that some people have a way of mitigating the disease for a longer period of time. And if you're familiar with the NUN study that was done a long time ago at UK, this is a prime example of it. When they looked at the brain pathology of some of these nuns who had donated their brains to science, a lot of them showed hallmark pathology, brain pathology in terms of cognitive impairment and dementia. But when you look at their writings and you look at their functioning reports, they didn't have any issues. So we know that some people can buffer the disease longer than others. And from an intervention perspective, if we can figure out the mechanisms, can we then tailor interventions to help individuals early enough in the process, maybe give themselves more quality time before they can't fight the pathology any longer. And so what's really interesting is that this concept has not been bridged to functionality yet. Even though functionality is used as one of the key components to diagnose severity in terms of dementia and Alzheimer's disease, most of the research looks at cognitive reserve in relation to cognitive abilities. And so there's been a push in the literature in the last 10 years to look at cognitive reserve in the face of functionality. Can we find an analogous functional reserve, and can we hone in on that to give practitioners and families more constructive talking points earlier in the game? And so some preliminary evidence from other colleagues in the United States has shown that when you look at driving behaviors and on-road driving tests, there are some associations with different brain biomarkers such as CSF tau, alpha, and p-tau 181, and all the different blood and brain biomarkers that can get at brain amyloid burden. Very little research has looked at it in terms of plasma-based biomarkers. So a lot of these original studies are relying on PET scans, and PET scans are very invasive. CSF lumbar punctures are very invasive. It's expensive. People don't want to do those things. So there's been a push in practice to validate plasma-based biomarkers because people are more likely to give a blood donation or a plasma donation versus being signed up for a CSF lumbar puncture, right? But we haven't validated that with driving in with those new biomarkers. And pretty much at this point, very little research has looked at cognitive reserve with performance-based driving. It's only been with self-report or with retrospective crash records. So the idea is that we don't really know what it looks like in terms of driving behaviors and then how those driving behaviors may be modified over time. So with this pilot study at the University of Kentucky with funding from NIH as well as from the VPR Office of Research, we sought out to first start to understand the association between cognitive reserve and driving mobility, and then potentially explore age and sex differences as preliminary pilot data for a larger grant. So we wanted to characterize cognitive reserve, driving mobility, and the plasma-based pathology biomarkers that we have from these individuals. And our biomarkers of interest include MRI volumetric summary measures, white matter measures, and then we also have APO genotyping on these individuals because they are long-term patients at the Sanders Brown Center on Aging, and plasma-based biomarkers. And then from there, once we've characterized what we have, our plans are to then look at the associations between these different variables while trying to look for any sex differences that may emerge with our sample. So again, we partnered with the UK Sanders Brown Center on Aging to recruit participants from their longitudinal cohort. They do a very extensive battery with these individuals, and these individuals have, some of them, been going to that clinic for 10 plus years, so that the rapport is already there. So we worked with them to do this initial pilot. We were working with older adults who are 55 and older. They must still have a valid in-state driver's license. Even if they're not a current driver, that's fine, but we still want that driver's license to be valid. And we don't want a formal diagnosis of Alzheimer's disease. So we're trying to catch the continuum before the diagnosis of Alzheimer's. And then for our individuals who participated in this first phase, they actually had just received an updated MRI scan before they participated in our study through a scanning initiative at the University of Kentucky. So from a temporal perspective, we were trying to get their biomarkers as close to their driving performance assessment as we could. And so we would have them come into the lab. They would do an hour of driving simulator work, so a brake response test and then a test drive. We would have them do a perceptual task called the useful field of view task, which looks at speed of processing and different attentional responses. We also had them report on their driving mobilities from a self-informant perspective and then a vision test. And so unfortunately, I don't have any data to show you on it. We are merging the data, but something that I would like to talk about is the driving simulator that we have and then how that plays into phase 2. So I mentioned before that we like to use driving simulation at the University of Kentucky. It provides a safe environment to observe nuanced driving behaviors and abilities. And it mimics real-world driving demands such as pedestrians, cyclists, and other vehicles. So if you think about it from a driving assessment perspective, if you're in an instrumented vehicle, if an individual starts to show dangerous behaviors, you have to stop that test right at that moment, right? You can't endanger the driver or the person who's riding with the driver any further. In a driving simulator, we can push the boundaries a little further because there's no actual risk to the driver or the people in the virtual environment. So we can let it play out as it needs to play out. We don't have to intervene, and we can actually observe behavior from a more controlled perspective. And the other really cool thing, as we talk about the different partners that we're trying to find at the University of Kentucky, is that it can be synced with biometric measures. So it allows us to look at eye tracking, it allows us to look at galvanic skin response, and the simulator that we have, it also partners with a company that does emotional regulation through face scan. So it allows you to determine what emotions the person may potentially be experiencing just by the micro expressions that their face is making during the drive. So I don't think we have sound, but I can show you. So this is what our mid-fidelity driving simulator at the University of Kentucky looks like. It does have a 3-degree freedom motion base on the bottom, so the person does get the right tactile stimulation, and then there's also roadway sounds that you can't hear, at least in this room. And so it's very customizable, and it's also a simulator product that is used across the United States, so it allows for a multi-site studies in case we ever want to partner with other medical institutes that have the same technology. So for the phase 2, and we are looking for partners and for people who are interested in working with us, but then also participating. So we're going to do another data collection that's more expanded for our grant proposal next year. We'll have them drive through our new driving simulator, again, doing some of the original tasks, but adding in other measures, and then also focusing on gait and balance and grip strength, as we know that these motor predictors predict functioning very well and predict quality of life as well as early mortality. So it's if you're going to talk about driving and someone's ability to maneuver a vehicle, you should probably talk about their motor abilities as well. So we've reached out to partners at Norton Neuroscience Institute in Louisville. They're very interested. They have a driving rehabilitation clinic there, and where they're starting to do preventative work and assessing people's risk before they have actual impairment. And so this is a perfect paradigm for us to partner with them, because if we can get people who maybe have pathology markers early but aren't showing impairment, then we can start to cater interventions earlier to their needs. And then we're also contemplating doing community recruitment and then potentially connecting with any driving assessment clinics that may exist in Lexington, although we haven't yet. So let me check my time. Okay. So the last thing I'll talk about is our population level study that we're also doing in collaboration with the Kentucky Transportation Center. So in this study, we're looking at social determinants of health and how it relates to behavioral crashes here in Kentucky using a multitude of different data sources that we have available. So I don't know if Bill had a chance to talk about this earlier, but I'm sure it's been shown in other talks here. But the safe system approach is something that USDOT has really put a lot of efforts behind. It acknowledges that human error contribute to a large percentage of crashes, but it doesn't take the stance that it happens in a vacuum, right? It tries to look at it from a holistic perspective in terms of all the different factors that matter in terms of crash prevention, but then also crash outcomes. As a social behavioral scientist in public health, I think the one thing that I talk about and I try to advocate for when we talk about the system is that risk and benefit are not equally distributed across individuals. And you have to consider lifespan forces and how they shape our experiences and risks. So someone's crash risk could be disproportionately different to another individual just based on where they live. And so while the U.S. DOT Safe System approach provides a more holistic view. I think keeping inequities and their impacts on safer people, vehicles, roads, speeds, post-crash care, you name it, it has to be at the forefront, because it's not, we can't apply just a one size fits all to all areas in terms of risk, right? We know that risk is going to be different. And what's really interesting is if you look at it from a social determinants of health perspective, there is a dearth of literature and not a lot of conversation in terms of how social determinants of health may impact crash risk for individuals and the outcomes that we see from it. So there's definitely a need for state and federal level studies on this. So the way that we got into this research at UK was we originally had a project that was funded at KTC that took a multidisciplinary approach to leveraging different types of crash data elements and geospatial analysis and crash modeling. So it was the idea that it would take all of the unique crashes from a 5-year period, merge it with the highway information system database to get all the roadway characteristics about the crashes that they could. And then from there, it went a little further and they geocoded the Unit 1 driver's home address so that we could start to look at census block group level variables with it. And the idea was that they wanted to merge it with this Esri tapestry data that comes from GIS Business Analyst Suite. It's used in the marketing realm a lot. It basically takes population segments and groups people by similar demographics and socioeconomic characteristics. So for that study, they were really interested in looking at these life mode groups in relation to crashes that we have here in Kentucky. And they focused on 4 of the main ones that are from a human perspective attributed to human error. And that's aggressive driving crashes, distracted driving, impaired driving, and unrestrained driving. So as we were doing the analyses, we started to look at some of the social determinants of health variables too, and we started to see some, I think, some interesting talking points that to us, warranted further investigation, maybe with better data sources. So originally with this study, what we saw was that drivers from census block groups with higher percentages of college degrees had lower odds of being in severe and fatal aggressive crashes and impaired crashes. But they showed higher odds of being in severe and fatal distracted driving crashes. So it wasn't like this pretty picture of like people with more education do fare better. And then other social determinants of health indicators that emerged, we saw some low-level correlations with race and ethnicity, as well as the absence of health insurance. And then, of course, because it's Kentucky, we did see differences in rural crashes. And so while the Esri Tapestry life mode analyses group based on similar demographics and characteristics, it's not designed to assess social determinants of health in the way that we think about it from a CDC framework perspective. And so in our next funded project that just kicked off at the beginning of the year, we wanted to look at these crashes, but actually do it from a true social determinants of health perspective. So our first goal in this study was to conduct a systematic scoping review on access to healthcare and how it was associated with these behavioral crash factors and outcomes. So trying to figure out from a state of the field, what do we know from all the other studies that have been done, from as much as we can find, so that we can at least start from there and not just keep replicating the same research over and over again. But then from there, actually with the crash data set that we have, start incorporating other elements of community health and resilience. So looking at not only the Esri data that from a marketing perspective, but then also looking at community resilience estimates. NHTSA is really interested in the Child Opportunity Index and how from a life course perspective that may be related to driving behaviors and crash outcomes over the lifespan. And then also the Social Deprivation Index. So all the different indices we can find to somehow get at the health of the community and how that might relate to driver behavior from a population level. And then lastly, the last phase of it, we will be using our driving simulator to do rural versus urban comparisons with aggressive driving and to look at different countermeasures that the state may be interested in. So right now we are doing this scoping review. We focus on healthcare access and quality disparities because if you try to do a scoping review on all social determinants of health, you'll be reviewing papers for probably 5 years. It's a very big topic. So we honed in on healthcare access and quality because in terms of trauma outcomes and quality of life, I think there's a clear connection as to why this would be a social determinant of health that we would want to focus on for crash outcomes. And so when we're talking about healthcare access and quality, we're talking about access to healthcare. So any studies that look at EMS, ED visits, trauma center, you name it, access to primary care, Health literacy, which is something I think that we've all become increasingly interested as we start to, as we're screening the papers, health insurance status, as well as medical debt. And so we are working with our librarian, our health sciences librarian at the University of Kentucky. You're shaking your head, which means you've done a scoping review before. So we looked at PubMed, CNL, Web of Science, TRID, and Embase, and all this is published open source. I had the DOI at the bottom. It's all open source on Open Science Framework, so that we're being very transparent about what our systematic review is looking at. We are currently, our team is reviewing 19,000 articles, but this is the reason why science like this isn't done all the time, is because it's a lot of work. But in terms of moving it forward from just saying like there's a disparity in healthcare access and it's related to worse crash outcomes, let's get a base of where we're at and then we can move on from it. And I think that's the goal, the first goal of this project. From there, we're working with the biostatistician group at UK to take our data set that's geocoded and then add all the community resilience estimates in. So we're actually going to start data analysis probably right after Christmas, which will be exciting. We'll be able to look at more nested relationships within communities as well as risk, and then urban versus rural sub-analyses. And then we're also in the process of developing Kentucky-specific scenarios with our driving simulator, with the thought that we can put Kentucky drivers maybe from at-risk neighborhoods in our driving simulator, have them go through different countermeasures, get their perceptions on it, and then also use it for further simulator crash modeling. So I'll end my talk. I know it's been a long day for everyone, and I feel like I might be able to give you a few minutes back. That driving is an important everyday function that has a complex association with both health and cognitive abilities as we age, so across the lifespan. And using both individual and population level approaches are important in this paradigm, right? It gives us a different level of analysis in terms of how biology and environment impact our driving mobility and crash risk. So it's not that one is better than the other, it's just telling different parts of the story that we can hopefully at the end combine together and produce better interventions that effectively work better for people. And another thing that I'm really am passionate about is working with practitioners and clinicians who have to have these hard conversations with families. We do pass the buck to doctors and their family members to talk about driving risk and safety with their family members. And so any research we do, if it can be translated into that space to make those conversations easier and more concrete, I think are important. Our different funding sources that we've had so far. And I thank you for your time. I have my email up there, and we are getting ready to launch our new driving lab website, which should be the link should be active, but I don't know how much stuff is really on it right now. So thank you.